Hi, everyone. My name is Brennan Day. I'm the Conservative MLA for Courtney Comox and the critic for Rural and Seniors Health. And I'm joined by Peter Milobar for this town hall on seniors health and rural health. I'm glad everybody could make it, and I'm hoping we have some productive discussions today about the state of healthcare in British Columbia and what that really means going forward in this conservative leadership race.
Hi, Brennan. Thanks for agreeing to host today. And yeah, I hope everyone home has some good questions for us, and we'll endeavor to cut through some of the noise out there and see what we can bring forward in the way of solutions as well.
Yeah, so I think we'll get started. Just give us some general conversation points on where you see healthcare in BC is headed today. I know we've discussed this in the House. We've litigated this fairly substantively with this NDP, and we know that the numbers aren't matching up. So tell us a little bit about your vision for healthcare in British Columbia.
Yeah, thanks. Well, coming from Kamloops myself, we've been experiencing, as you would in your own community, the steady decline and erosion of healthcare. And so when we see a Clearwater Hospital emergency room shut down over the last several years, multiple times, when you see Merritt, when you see 100 Mile, when you see Lillooet shutting down, it puts a lot of pressure into the Kamloops emergency room. And so that's that rural healthcare aspect of it. But what we're starting to see down into the lower mainland is effectively the same situation because when you have an emergency room wait time in Surrey of 13 hours, that emergency room is essentially shut. It's on a 12-hour break for that person coming in and having to sit in that waiting room for that length of time. So we're really starting to see that impact roll through the province. And what's shocking to me is how little the frontline staff have been listened to by health authorities across this province, by the
Absolutely.
government, and how much money has actually been going into healthcare. As I've been touring the province and letting people know that when the NDP first took office in 2017, the healthcare budget was $17 billion. This year it's at 40, and people are shocked by that, and they're wondering, well, two and a half times bigger budget. Where's the result? And it's ever declining instead of ever getting better. And so it's those types of things I think we'll hear from people tonight as well, and be interested to see where people's concerns lie.
Yeah, that's fantastic. So for everybody viewing online, make sure you get your questions in there. We're going to have a robust discussion here. So if you have questions or, individual cases that you want us to talk about, please make sure you pop them into the chat. I know that in a lot of the work we've been doing, the numbers don't match the reality British Columbians are seeing on the ground. We hear about the attachment rates that the government constantly announces. I think the most recent one was 600,000 people attached since 2023, but we know that's not the reality that people are facing here on the ground. So I guess to go into it a bit more detail, what do you see as the solution to the problems facing BC healthcare today?
Yeah, and one of the things I committed to back on January 16th, I guess it was the day that I launched my leadership race, was that we would have accountability under my leadership as the premier. And what I meant by that is we'd actually have tangible guideposts, targets for not just in healthcare, but across government that would be very publicly shared, very understandable, and we would actually know what it is we're actually striving for an outcome on any given program. And so what we're seeing in healthcare is this complete hiding of what is going on in terms of wait times. We're seeing a complete refusal by the government to acknowledge that in fact things aren't getting better. And so to me, sunlight is the best disinfectant. And I think if we share in honest conversations with people like that are online tonight and across the province, including while we're in government, most importantly while we're in government. I think that's very critical that people understand what is the target we're going for a wait time for an emergency room visit. What is the target we're going to for a diagnostic test? What are those targets? And then report out on a regular basis whether or not we're actually hitting those benchmarks. And if not, explain why. Explain because we need to get more staff or this. The reason I bring that up in relation to what you were talking about in terms of the clouding of the numbers. Now, I think back to last year when the minister, and she continues to talk about 1,000 new doctors in British Columbia. Yet when you press her in budget estimates, where they can't just deflect away like they do in question period, net new doctors is actually 400. And so the other 600 just replaced retiring doctors. And so that perception the public hears from the government is 1,000 new doctors. But in the real world, when people are seeking a doctor, it's actually 400. It's still better than zero, but we have to be honest with the numbers with the public, because otherwise, how do you know what the true gap of service actually is?
Yeah, absolutely. I mean, I bring this up with the minister on a regular basis. You can't fix what you don't measure, and it doesn't seem like they're measuring some fairly major metrics like wait times to see a specialist in this province aren't measured by the health authorities, which is it's just shocking the state that we're in. We've got a few questions coming in now, so I'm going to this one is from David. Hello, Peter. Though I understand the issues with hospital emergency shutdowns, what is alarming is that in my town, we have had over 35 diversions in a year, though it never makes the news. How is your government going to correct this very serious issue? And we're hearing that it's not just one hospital, this is across the province. We had a release that we received through FOI to the health team. And it was shocking the number 19 closures in Tumbler Ridge just in the first half of 2025. So what are we going to do about that? We know 100 Mile House is facing constant closures. The goalposts seem to be constantly shifting. How do we bring British Columbia back into this conversation?
Yes, and thanks for that question, David. And you know, it's really critical. Again, I don't pretend to have all the answers, or that things that I propose will solve every possible outcome. That wouldn't be realistic. And frankly, any politician telling you that, you should be very leery of making those types of claims. But you know, I did try bringing forward some solutions to the health minister, and they were dismissed out of hand. And I used Kamloops as the example, but you know, when you look at a Prince George, when you look at a Kamloops, a Kelowna, Nanaimo, these centers are typically almost like the center of the sphere around of these smaller hospitals where the diversions and the closures happen. And so what I was proposing was, in the case of Merritt and in the case of Clearwater, a lot of times the closure was because of a nurse not being able to show up for work for sickness, or other reasons that come up last minute. Understandable, life does happen. I said, well, you know, one nurse leaving Royal Inland Hospital in Kamloops to backfill is not going to create, you know, that Royal Inland Hospital will be shutting down, but it is literally shutting down other emergency rooms. Could we not have one designated position on shift at any given time that agrees, and getting paid a premium for that shift, knowing that if the phone call comes, they're immediately the one at pre-identified that is willing to drive the 45 minutes to Merritt, or an hour and a half to Clearwater, to make sure that that
Mhm.
emergency room can stay open. And then the next shift coming in would just automatically divert over to that hospital as well, instead of showing up to the larger regional hospital. That was just dismissed out of hand. No discussion with the nurses union, no discussion with healthcare professionals about how to make that feasible or not. So there's a lot of things like that that we could actually dive into, and find some lower cost redundancy in the system by relying on the bigger hospital in the region. And that's just more in the rural setting. Obviously, now that we're seeing diversions happening in Maple Ridge and in Peace Arch and in Delta Hospital,
Mhm.
it's creating a bigger ripple into the more urban centric lower mainland. So bigger issues there, but we have to be unafraid to actually start challenging some of these ideas, and start saying what is the lowest cost way to bring some redundancy in, so that everyone knows what the plan is, as opposed to running around surprised that we have yet another diversion or closure, because they happen fairly frequently, unfortunately.
So we've got another question coming in from Barbara. What is your plan to fix the healthcare system? And I'm gonna add a little bit to that because that's too broad a question. You know, we're in a leadership race, and I think British Columbians really want direct answers. So, what are the top three things in the healthcare system that you're going to focus on right off the bat to get things moving again for British Columbians?
Yeah, thanks. So, you know, I think a lot of it comes down to a mindset of problem solving, and looking at, you know, what is it that we're actually, where is the bottleneck in the system on any given thing? So the one example I've been using, unfortunately, this year's budget, there were 6 long-term care homes that were removed from that budget. Why does that matter? Well, we have a shortage of seniors long-term care beds in this province. The advocate has very clearly stated we need 16,000 by 2035. So it seems canceling 6 projects is a problem. But they canceled them because the government says they can't afford the 1.8 million a bed, which I agree. But the private sector says they'll build those same beds for 600,000. And so it's an ideological reason that the government's not proceeding, not a fiscal reason. Why that matters is that senior that can't get the long-term care bed is sitting in an acute care room, tying up that space in an inappropriate housing model, It's not great for their mental health either because they shouldn't be in a hospital setting. They should be in a long-term care setting. But that fills up all those acute care beds, which then creates the hallway medicine we keep hearing about in ever-growing numbers, which then puts pressure back down into the emergency room,
Mhm.
which then puts pressure into the emergency room waiting room. And that's how you wind up with 12 and 13-hour waits in a waiting room. And it puts a whole lot of extra pressure on all of those staff, which does lead to the burnout, which leads to staff being away, and that ripple effect. And so the thought process of the government was, well, let's save a few dollars on the
Mhm.
capital end because of ideology, and we'll worry about the operational dollars and the worsening health outcomes and patient outcomes on the operational side as a totally separate problem.
Mhm.
And I think when you look at all those pieces together, that's three pieces just in and of
Yeah.
itself. If you just reframe your thinking, again, it won't solve everything, but what we're currently doing just simply isn't working. And so by putting more capacity into those choke points of the system, it actually does free up more capacity in the acute care hospitals
Mhm.
for that throughput of patients and patient quality and patient care and patient outcome, and ultimately better work life for the frontline staff as well.
Yeah, fantastic. Well, this is a great segue to the next question from Robert in Courtney. Everyone talks about how top heavy our healthcare system is. If that's the case, what is your plan? And I think you're the perfect person to answer this because we've been talking a lot about this in caucus.
Yes, and again, I'll give some examples. When I talked to a supply company that had 13 invoices worth $16,000 for in-home devices, they were getting reviewed by a health authority. So I'm all for checks and balances and making sure invoicing is correct and proper. The owner and the bookkeeper went into this 3-hour meeting. They had 9 senior finance managers for the health
It's a
authority attending.
$16,000 meeting right there.
Yes. So, they would have met before the meeting, they would have debriefed after the meeting. All those invoices were actually ultimately approved. And so, again, the materiality of what we're seeing in terms of the number of dollars being spent in those management levels is really shocking. And I think there's a space for us to also dive into. We've seen fewer and fewer on the elective surgery side, those centers where you could go. MSP still pays for it. It's still publicly funded, but you could go and get to what they consider an elective surgery or procedure done and still covered by medical services premiums. My sense of that is part of the reason we're seeing those not function as well is the health authorities and government doesn't truly track what the cost of that same procedure inside the hospital setting actually is costing us in terms of staff time and space and square footage space and everything that a private operation would actually do. I have a very good sense that if we dove into those numbers, we could actually ramp up the volume of those non-elective for less tax dollars and not charging people. Once again, I want to be 100% clear because I don't want the NDP to try to pretend that I'm saying something I'm not. Still have it covered, still be paid for. But that would also then free up that capacity. So less money being spent by the taxpayer, more procedures being done overall for those particular issues. And then that would actually free up more operating time and space in the hospital itself for those
Mhm.
more substantive surgeries that are backing up and backing up. So again, we have $40 billion to work within. Surely we can start finding these efficiencies and ways to better deliver. But it starts, in my opinion, a lot of it starts by listening and respecting the frontline staff in the wide range, not just doctors, not just nurses, but the technicians and the respiratory techs and the radiologists, like
Yeah.
everybody that has those touch points with the patient
Mhm.
on how to better have that patient
Mhm.
throughput and make their own job site more efficient at the
Yeah.
same time.
Yeah, I mean, we know it's one of the biggest growths in healthcare right now. 3 times the rate of staff costs is just on the administration and the health authorities, and that doesn't even count the administration we see in the hospitals. So absolutely massive problem. Fantastic question. I'll move on now to Victoria. Thanks for stepping up to the leadership race, Peter. Surely the answer is not a flood of more money that we do not have, but to implement regimes that our peer countries, not including the US, uh, have have that yield much better outcomes for substantially different costs. And I think that's a great question because we're in the trap here in Canada where we always get compared to US style healthcare.
Mhm.
And that is the go-to line from the NDP whenever they want to criticize policy that is critical of what they're doing. But we know that in the G7, they have shorter wait times, better outcomes, and they're spending materially less than we are here in Canada. So, with that, where do we look to for these, novel ideas that can help buffer our system against this absolutely explosive spending?
Yeah, and thanks, Victoria. And again, I mean, the NDP will try to paint us as conservatives as wanting, two-tiered U.S. style healthcare. And on that, I'll just say, remember, it's the NDP who let our cancer care get so bad that we had no choice but to start contracting with private Bellingham hospitals for cancer care for BC patients for a couple of years. And I fully supported that having to happen. I wanted people to have their cancer care. But when they talk about, they're the only ones that know how to handle the healthcare system, it's a bit rich when
Yeah.
they're saying that.
Sure.
But I totally agree. And that's where I say that transparency and understanding of what we're driving towards, it gets management on board, it gets the frontline workers on board. The public starts to understand what is the end goal, what are we actually trying to achieve. And right now, when you ask the NDP as the critic, or I ask as the finance critic, a question around healthcare, they revert to how many dollars they're spending as the success. And that should not be, I don't think the patient waiting for a hip for 9 months, and that's probably a short wait time for a lot of people that are watching right now. I don't think that they think that's really the outcome they're looking for. They're looking for fast access to hip surgery. When they take over all of the diagnostic centers out there, and we're seeing longer and longer wait times for diagnostics now. That is not a success to me. That is an ideological decision they made to go out as a government and
Mhm.
buy up all the imaging centers, and say that somehow that was providing a better service to the public. I think the public still wanted to not have to reach into their pocket to go to an imaging center. I totally understand that and agree with that. But they actually wanted the imaging done in a timely way.
Mhm.
And so again, it's about reframing how we're looking at this. And I'm a firm believer, not just in healthcare, but in everything, that you actually have to know what the target is we're trying to achieve. So we actually know what it is we're going for, and then we can start problem solving, and we can find efficient ways to deliver top line services for people, knowing what that end result actually is. And I know it sounds like platitudes and it sounds very simplistic. It's not. I understand how complicated the healthcare system is. And I understand the complexities that we will face with various unions and specialties and subspecialties and everything else, and the pushback you'll get. But we don't have a choice. We're at the breaking point, quite literally. And so I think even a lot of those same um, voices that normally would have pushed back a lot harder, I think they are desperate for change as well. I
Mhm.
can't imagine anyone in healthcare, regardless of where you work in a hospital, is going into work every day thinking, you know what I want? I want worse patient outcomes. I want families to be more in distress. They got into the health sciences for a reason because they wanted to help people. We need to work with them, that great workforce that we actually have, to figure out how to get those efficiencies and not be afraid of having those different views of how to actually deliver that.
Yeah, I mean, this government seems really hung up on measuring inputs and not outputs. And I think that is one of the critical problems I see within the healthcare system is that they're spending more money. They love the big announcement, $2.7 billion more spend, but in reality, it's a cut in real terms when you factor in the wage increases and inflation. It doesn't make any sense. It makes for a good headline, but we've got to sort of switch that mentality because people don't measure inputs. They only
Yeah.
measure what they're going to see on the back end.
Well, and just on that real quick, like, when we talk about efficiency, so, and if it is, and it is a functional cut, as you say, because when you factor in the wage settlements and everything else, that simply doesn't cover it all. But then explain to the public where other efficiencies have been actually found,
Mhm.
instead of trying to pretend it's a dollar figure cut. It doesn't mean it has to be a cut to overall service to the public. And when you have, doctors saying that they need help with the charting software and ways to make that more efficient, and with government's help, to free up the equivalent of 1,500 GPs.
Mhm.
Okay, let's say they overshot the runway on that. 750 GPs, that would still be twice as many net new GPs as what we currently
That's right.
saw come into the system. So there are these types of efficiencies that, again, if we don't just focus on the dollars and focus on the outcome, that to me is actually truly what actually matters. Again, no one sitting in an emergency room or in an ICU tonight, their loved ones are sitting there wondering, I wonder how much they're spending on healthcare this year. They're wondering why they're having to wait a little bit longer for a test to be done. And that's what their
Hmm.
concern is. So we have to get back to getting that efficient workflow.
For sure. So we're going to switch gears here. We've got a question from Zach. Can you speak to your plan for long-term seniors care? And I'm going to give a bit of background on this because I think it's really important British Columbians understand how bad the problem is right now. Currently in the province of British Columbia, we've got 7,400 seniors waiting for a long-term care bed. The average wait times are wildly different across the province, depending on what postal code you live in. We know we need 16,000 additional long-term beds by 2035 per the latest Seniors Advocate report. And today we're already 2,000 beds short, which based on the cancellation, we're going to be 3,600 long-term care beds short by this time next year because of the cuts. What are you going to do to fix long-term care in British Columbia?
Yeah. Well, again, I think we have to get away from the ideology of it. Now, do we have to make sure, absolutely, if we're going with private operators, that they have a standard of care laid out and that it's funded properly and appropriately, and it's a very clear understanding of what those service levels are, and they're held to that? Absolutely. But if they can build a space for one third of the cost that the government is currently getting pricing for, and we have a $13.5 billion deficit. We have an ever climbing debt, and we have a healthcare cost system that's spiraling out of control. And we know that the seniors' lack of long-term care beds is putting that pressure into our acute care system at a much higher cost. We have no choice but to do it. Like this is where you have to separate ideology from that. So that's this is a good starting point. When I see other things that was happened in this year's budget, the seniors property tax deferral program getting changed, and so it's now compounded monthly, and it's prime plus 2%, a 4% swing in the interest rate. That will actually have a material effect on a lot of seniors, especially in lower income
Mhm.
housing, that are trying to stay in their own homes. They're trying to keep what equity they can in their homes. So for that day that they have to go to a long-term care facility, they still feel like they can make it work. Now, the health minister or the finance minister says, well, it's because people were using it as an investment tool. Fine. Put in income thresholds testing. Just because you live in have a bigger, older home doesn't mean you actually have the income to match it. It just means you might have literally lived there for 50 plus years.
Yep.
And so, if we're trying to, and we have a shortage of long-term care facilities, this year's budget has done nothing. Not only did they remove 6 projects that were already funded and approved, and money was spent last year on them, but they've added in all these other layers of taxes for seniors that are actually trying to stay in their own homes when they have no long-term care facility to actually move to. And so we need to actually be looking at these things much more holistically,
Hmm.
and that's how we start addressing some of these seniors issues, and realizing that when they're on fixed pension incomes, again, I'm a fan of income testing, not age testing. So if you have very wealthy seniors, I'm less worried about their access to pharmacare or things like that, because they can still afford it, obviously. But for those seniors that are on very low fixed pension incomes, we have to be alive to that, and we have to be taking steps to actually meaningfully address that.
Yeah, it seems very interesting. I mean, from last year's budget to this year's budget, we saw a massive shift between a push for at-home supports in last year's budget, which didn't really materialize, and then this year, nothing for at-home supports. And at the same time, they cut the long-term care. There's a lot of work to do in that system. And it's quite shameful what's happening. We're going to move on to a question from Brian. On Vancouver Island, our health authority spends almost 70% on the Victoria area when 50% of the population lives north of the Malahat. Why? And this is an interesting question for me and certainly all of the constituents I have listening at home because we're certainly a uniquely underserved area on Vancouver Island. Everybody's in Victoria. I know, when my wife had pregnancy complications, we ended up down here for nearly 2 months. So huge costs for travel in rural BC, and we'll broaden it out. This happens when people have to go to Vancouver too. So, what are we going to do to address those rural inequities in BC?
Yeah, and I experienced those in Kamloops with Interior Health, with Kelowna and Kamloops being in the same health authority. There's always that battle back and forth, and we see it in Fraser Health Authority. There's about 40% of the population of the Lower Mainland lives in Fraser Health, and they get 22% of the budget. And so, they're experiencing the same thing. What we need to do is we have to take a serious look at our health authorities. We have to rein them back in, because the inequities are just getting too great. And I remember saying years ago when I was the mayor of Kamloops, and I was the hospital board chair at the time, and I was talking with the head of Interior Health, and they said, but it makes more sense for us to locate, I can't even remember the service now, in Kelowna. It's economy of scale. I said, yeah, but that's a self-fulfilling prophecy.
Hmm.
If you just keep loading everything up into the same hospital, of all these new services that are going to be funded, and the province wants to bring on board, it creates more and more inefficiencies, in every other area. And then it's easier to say, well, they're not as efficient, so we're going to put even more in. My mother-in-law had to go and get, it was either her hip or her knee that was replaced. She said both. I'm not sure which exact procedure was done in Kelowna, but she had to go to Kelowna from Kamloops and get it replaced by her Kamloops surgeon in the Kelowna hospital. So there's travel costs to the family, and days off of work and all of that. That's an impact that shouldn't be happening, and we're seeing that play out, as you say. In the North Island, we're seeing it play out in Fraser Health as well. We have to bring more equitable access to that care, and I think, frankly, being the only candidate in this race from the interior, from a city that deals with this on a regular basis, I have a very full and clear understanding of just how dramatic of an impact this is for those families that live in northern and interior, and by northern, I even mean Northern Ireland, interior communities, that are separated away. If you're in the Kootenays and have to try to get access into Kelowna, and it's actually easier to get to Calgary, and it took the province years to re up with the reciprocal agreement so that patients from BC and the Kootenays could get access into Alberta. So we have to be alive to this, that these are large distances. And when an emergency room closes and it's the middle of winter and you're going through a mountain pass to try to get to an emergency room, that's not the safest thing, especially with limited daytime hours. So,
Hmm.
I don't know the exact reason why Northern Ireland is being treated that way, but I would suspect it's very similar to why every other health authority is structuring things the way they are, and they create these motherships, and then everything else kind of it comes at a cost to it.
Hmm. Yeah, certainly. I mean, Brian, the catheterization, the lack of a catheterization lab in Nanaimo to serve the whole North Island. The fact of the matter is, in the G7, we have the largest population that's not served by a cath lab in the G7 north of the Malahat. And, I don't know how long they've been talking about the new hospital tower in Nanaimo. That hospital is getting long in the tooth is an understatement.
Yeah.
So,
Well,
absolutely a great question.
I don't want this to turn into who has it worse at night, but I'll just say this to Brian. And you brought up a cath lab for Nanaimo, which I fully support. And I fully support it there because in Kamloops, we actually have cardiac surgeons that want a cath lab. We have the population that would
Yeah,
require it. We have the space in the hospital, and we have private donors willing to outfit the whole suite.
yeah,
And our health authority has told us we can have that in 2040. So believe me
yeah.
when I say I understand what people are getting frustrated about with health authorities, and what we need to do, and what I need to do as the premier to try to get things back in line.
Absolutely. So we're going to move on to a question from Bill. With seniors projected to need 300,000 more care beds, I think you mean 30,000 more care beds in the next decade, and a critical shortage of healthcare workers, what is your plan to address both the infrastructure and the staffing crisis in seniors care, especially as burnout drives nearly 40% of nurses towards leaving the profession? And it's not just 40% of nurses. I know 40% of family practitioners are also planning on taking retirement in the next 5 years. So we've got a fairly looming crisis ahead of us. How do we balance those two? Because we're still trying to draw water from the same bucket, and we know it's full of holes. So,
Yeah, and I've given this a lot of thought, and I talk a lot sometimes about this being with say doctors, but I think we can actually, it's transferable to many other professions as well, in the health sciences. And we graduate a heck of a lot of kids from high school in British Columbia every year. We've invested in them as taxpayers. They go away to other parts of, not just Canada, but they go to other parts of the world, and there's a lot more of them than people might think at home that do this. We need to start seriously looking at accrediting various institutions around the world, not just within Canadian borders, but around the world, and say, okay, and define which specialties you're okay with, be it a GP or be it a respiratory tech or be it a nurse or any of those, and actually start accrediting those actual institutions. And let our graduating kids know that if you go to any of these specific schools for these specific courses, you're welcome back as if you went to UBC or went to Thompson Rivers University or went to,
Hmm.
and because we trust where you got educated. We shouldn't worry about the border on a map. It should be, if it's good enough in University of Alberta and it's good enough in University of Ireland, what difference does it make that it's a different country? We've invested in these kids. They grew up in BC. They went to high school in BC. They understand the culture. They understand the language. That's always a reason that's given for taking longer to bring in, international trained people. But then we could also actually be seriously looking at fast tracking some of those international people as well that have been trained at these same
Hmm.
institutions. And so, like, we need to take ownership and start looking at the post-secondary system on that global basis of saying, how can we, with still maintaining patient safety without draining, third world countries from their medical staff as well, bring out the welcome mat to graduates from very targeted and specific institutions around the world, because a
Hmm.
lot of kids, either for one reason or another, can't get in, want a bit of adventure as they're going through their early 20s, and they want to travel and go to school and live in a different part of the world, but then they want to come home.
Yeah.
And we should be welcoming our kids back home, not saying to them, essentially, we kicked you out. We're going to make it next to impossible for you to come back if you want to do your profession that you've now gone out and trained in. So
Yeah.
again, it's not meant to be the cure-all, but it definitely starts to set that mindset, I think, and starts to drive us towards providing kids even coming through school as realizing, okay, there's options for me here. I don't have to stress about getting into just UBC,
Hmm.
and if I don't get one of those seats, I'm done, and I have to try to figure out how to afford to live in Toronto instead, and can't do that. Let's leverage post-secondary to the best advantage we can around the world, as other countries do with our post-secondary institutions. This is why it's so
Hmm.
crazy to me, right? How many kids come from other countries to get trained in our institutions to go back home to their countries? We need to start doing the same.
Hmm. Yeah, certainly. I mean, I know in my grad class, I think we had four doctors, three of which trained down in the Caribbean to come back. Only one actually ended up going to do their training here, and that journey back was very difficult. And I know certainly through the emails I've gotten as critic, the number of doctors in the United States that are trying to come up here and navigating that credentialing system just from the United States is wild. The stories you hear
Yeah.
in terms of how disjointed that system is. I mean, we hear a lot of rich talk from the minister, and I don't think the reality matches the press releases again. So we're going to move on to Vija, and she asks, regarding long-term care, can you fund the government share to the family so that they can look after their loved ones at home? And I think that's a great question because we didn't see anything in this budget, certainly, that really identified how we were going to keep people at home and
Mhm.
how we were going to keep those caregivers from just burning out. I know, I mean, even my CA is struggling with a parent at home, and it's not getting easier. The supports are just so inconsistent. So how are we going to sort that out for British Columbians and make sure we keep those, the caregivers in the workforce as well, because it's a huge impact if they have to take time off.
Yeah, no, and I started out today by essentially saying everything's got to be on the table. Like we're at a point we have to be willing to have these conversations. Now, admittedly, I haven't given this a ton of thought. I get what you're going for and striving towards with the question. But it's problem solving like that we have to be open to, and especially if we're having problems finding staff. I know even for home care, the home nursing cohort is always a problem in terms of shifts being dropped, people going extra days between when they're supposed to have help come into the home, and so we have to be realistic to what is actually happening in the real world. And I know some people would be saying, well, that's what families should do, but it does sometimes come at an extra cost for the family to find some of that extra respite care and things like that. So I think everything like that has to be on the table and have these conversations of it doesn't mean it's a dollar for dollar subsidy like it might be in a long-term care facility, but we have to start finding value for the taxpayer to deliver the type of end result we need. And if the end result is seniors being housed safely with good quality care, and if that can be accomplished for less dollars while still having them in and around loved ones,
Mhm.
I'm open to those conversations and trying to figure out how to make a program work.
Fantastic. I think we're going to skip by a question from Andrew. It was considering using doctors from other countries, so I think we covered it. He does mention nurse practitioners, which is I think is a great conversation as well. But we're going to move on to Bruce, and he asked, "Will you engage with physicians groups such as the consultant specialists of BC to explore their views on how to solve specific problems within the system and allow doctors to actually be part of the solution, which has not happened under the NDP?" And I can tell you, I've had a lot of conversations with many concerned groups about the lack of autonomy and this government's inability to listen to the people that are actually delivering the care. So, what would you say to Bruce?
Yeah, and to Bruce, I'd say they have reached out to me a few times, and we've exchanged a few emails. I know when I was shocked and saddened by in Kamloops, we had all seven of our OBGYNs resign en masse in the summer. And there was some contact point there as well. And admittedly, in the heat of a leadership race, time has been scarce to have those more in-depth conversations with those more targeted groups of specialists and healthcare professionals. But absolutely, that's exactly what I'm talking about. We when I was the mayor of Kamloops, we found a lot of efficiencies in the city. And we did that because we actually listened to the frontline staff a lot. And it didn't mean we listened and did every single thing that they wanted to see done. But their work improved. We saw grievances drop. We saw work safe claims drop. We had labor peace. Their job satisfaction went up. The delivery
Hmm.
of core critical public services was improved. And we did it more cost effectively. And we actually kept property tax hikes at or under the rate of inflation for many, many years. And so that's the mindset I come at this with is we have to be willing. And again, it doesn't mean you agree to everything. But if these groups want to come in good faith and actually not just be a siloed conversation where what's best for them, and if it creates issues for everyone else, then nothing's going to happen. We have to actually start pulling these groups into the rooms and actually truly engaging and truly listening to not just um, um, an exercise of fake kind of consultation, right? And I see this across the board. We had a cancer center designed in Kamloops, so they never once talked to any of the local oncologists of what they wanted to see in a cancer center, and it's a mess of a design. It's not functionally going to work as well as it could or should. It's that stuff like that we have to, get past doing it the way it's been done in the past because it's simply not working.
Yeah, fantastic questions also from all of the people watching. I think this is a great conversation. So we're going to move on to Stephen, and this is about addictions care. So we have two-tiered U.S. style healthcare in addiction recovery treatment. How would you approach both the harm reduction and the treatment continuum of care?
Yeah, great question. So, it gets complicated, obviously, right from the hop. So, and when I use the downtown east side in this, it's just I recognize it's happening in every city, but
Yeah.
it's the easiest example that we always hear and see about on the media and that. But so we have the people on the downtown east side that are suffering, right? They can't care for themselves. It's very obvious. They have brain injuries from multiple non-lethal overdoses. They have underlying mental health issues from years on the street and the living conditions they're in. Physiologically, the drugs, what they're doing to their skeletal system is ravaging it. So a lot of people now are walking around with spine curvatures where they're almost touching their toes all day long because it's too painful to
Yeah.
not walk that way. They're being preyed upon. They're in weather. Yes, they technically have an SRO, a single family occupancy room to live in, but it's very depressing for them to be in there. So they'd actually rather be out on the street for most part of the day in the elements and in the violence. And we have to recognize that they're not able to properly care for themselves, and we need involuntary care.
Yeah.
And that needs to be ramped up. It needs to be ramped up in more than just Riverview. It needs to be ramped up around the province. But then we also have to recognize that, and again, in this example, I always use a construction worker because statistically, it's a very high prevalence of it. You know, they get injured on work, they wind up on a painkiller, they get addicted to it, they start self-medicating. Their family convinces them they do have a problem. They want to seek treatment. There's not voluntary care access, and this is especially true where you're talking about the two-tier system, as the question would indicate. And so, if they can afford, $40,000 a month to go to a private center, they can go right
Yeah.
away. Not many families can afford that. If they want to wait for a public space, they're told 4 months. They're told 6 months. They're told phone every day at 6:55 in the morning and see if you can have a space before 7 a.m. Well, those moments of clarity we all know are fleeting.
Hmm.
And so that starts them down that road to the downtown east side. We know what the end point is. It's unfortunately
Yeah.
either death or the downtown east side. But you don't start being, you're not an addict and you instantly jump to the downtown east side condition. There's lots of checkpoints in there if we had a proper voluntary care system in place. And what we need is the private centers to be properly accredited so we can point to it being proper medically um, backed up treatment and recovery. And we need to still have the public system. And if the public system's full, the public has to backstop and pay for the cost of the private space. The person asking for care that day isn't asking for a specific center. You're sending them to where there's a bed available. Some of those beds will be cost less than others, but on an aggregate, we know what it'll be. Alberta's done this quite successfully. Yes, there's people with relapse and everything else that goes with that, but we have to try, because if we don't actually properly build up that voluntary care side of the equation,
Hmm.
we do know what the end result is. It's a slow uh, endpoint to get there, but we know where it's going to be. And
Hmm.
so otherwise, all we're doing is continuing to clean up the downtown east side problem, as opposed to actually capturing the problem in its infancy and letting people get back with their loved ones, their families, and being productive people in their own family lives and enjoying their life to the fullest again.
Yeah. Fantastic. Okay, we've got a question now from Bill. BC debt has reached $13.3 billion, largest in history. As a result, Burnaby Hospital has been delayed, and 7 long-term care facilities have been delayed due to rising construction costs, and wait lists continue to grow. How will your government ensure seniors aren't left in limbo?
Yes, and thank you for bringing up the Burnaby Hospital as well, the patient care tower and cancer care. So at a time again where we have had to be sending cancer patients to Bellingham to private U.S. hospitals, this government's wisdom was to cancel cancer center. And I say cancel because in the budget, what happens is with projects when they get delayed by a year or two, so they'll tell you it's last year's budget might have said 2028 completion. And then when there's delays, they say 20, in this year's budget, they'd say 2029 completion or 2030 completion. This year, they didn't actually put an extending date on these projects. These were all listed last year. They were all approved last year. There was over $100 million spent on these projects already for prep work and design work and everything else. And instead of just extending the date out by a year or two to say we've hit a bit of a roadblock, they've literally just said TBC. So some say to be concerned, continued, to be confirmed. I say to be canceled. And so it is a big problem. And so again, it ties in, to our earlier discussion about these long-term care beds, creating a capacity issue within acute care hospitals. And we need to get past the ideology of government knows best, of that only government can build and operate long-term care facilities and deliver good service for people. We have to recognize that if we put the right accreditations and right standards in place, the private sector is ready and willing and able to provide these services, not just for necessarily less operational dollars, because there's wage scales and everything that will be very similar. We're talking about the capital side,
Hmm.
and just that alone would create a lot of space. And then what does it save in the acute care system if we actually free up that capacity? It almost feels like the government is not wanting extra capacity in the acute care system to be opened up, because then they'd have to explain why there isn't more surgeries happening and there isn't
Hmm.
more access to the emergency room quicker. It's almost like they're willing to let seniors suffer in inappropriate care or non-existent housing, just to try to mask over other issues within the broader healthcare system.
Yeah, I mean, further to that comment, and it leads us very well into the next question. I heard a deputy minister at a conference last week, and the person that's asking the next question was at that conference presenting, actually. And the deputy minister said, it doesn't matter if we save money in one side, it'll get spent somewhere else in the healthcare system. So that's not what we're looking at doing. And I think that's very clear. The way that they're juggling those dollars is I don't think they have an idea of how to fix this system other than to throttle care for British Columbians, which is absolutely the wrong way to go. And it's certainly not putting the patients first. So the next question is from Cassandra. What is your plan on medication access for incurable diseases that are available in every other province but BC? For people like myself, these medications can mean the difference between keeping vision, mobility, and dependence. And I'll just add to that, there's 32 drugs right now that are offered in every single other province under the Medicare program, but BC. And BC's position on this is we spend 40% less on pharmacare, and they tout that like a good thing. And it's debatable whether it is or not. So, what do you say to Cassandra in terms of how we bring BC up to the standard of the rest of the provinces?
So I have huge issues with what we're seeing happening right now with access to various medications and equitable um, access to drugs. I'm still tracking down, but my understanding from a whistleblower is one patient, one addict that is getting 18 fentanyl packets, slow release patches on every day or two, changed out by a nurse. And the drugs alone, without dispensing fees, are $90,000 a year. Because Suboxone and others like that are not working, but they won't send the person to treatment and recovery. Um, so when I hear stories like that, and I think of Charlie's case, and I think of others as was just questioned as well,
Cassandra here.
um, it really does make me wonder if we've not lost the plot here, if government has not lost the plot in terms of people that are working hard, paying their taxes, expecting the backstop of government, by a government that tries to lecture all of us as conservatives as being mean-spirited and cold-hearted. And yet, as MLAs in our constituency office, we routinely hear of situations like this around medications. Now, I fully recognize you don't want politicians meddling in all medication efficacy type decisions. I do understand that. But we seem to have gone very far the other way in terms of how this whole system is working. And again, it's that lack of clarity and understanding, a system that's now been designed where you don't even know who the decision makers are. They're not beholden to really provide any public information, and we went through that with
Hmm.
those other cases. And so, I feel the system needs to be revamped. We have to take a serious and hard look at what we're spending on some of these programs. And when I hear the situations like I heard with the fentanyl patches, and apparently there's a lot of people like this, and that's what I need to dig into and track down to figure out just what are we spending on this program around these types of treatments when we have other people that are desperately looking for help and being told no. Because we're in tight budgetary times, but other programs are seemingly never ending with their funding.
Yeah. Well, we're getting a little tight on time here, and I don't think we're going to get to everybody, but I'm going to desperately try. So the engagement here has been absolutely phenomenal. We'll keep going. We've got about three more questions left. The next one is from Adam. Peter, thanks for stepping up to run for the leadership of the party. With the new Health Professions and Occupations Act coming into effect in April 2026, Doctors of BC has warned that increased government control could lead to a less physician-friendly environment and worsen our already acute shortage of specialists. How specifically will you ensure that this new regulatory regime actually improves patient care rather than driving more doctors to retire early or move away? And I'll just add to that question and centralize that control in the bureaucracy, which I think is even more terrifying,
Yeah.
right in the minister's office. So,
Yeah.
what do you have to say about the HPOA and its impacts?
Well, I'm the only one already in this race that's currently in the legislature. I'm also the only one in this race that was actually in the legislature when the HPOA was brought in. and I spoke against it and I voted against it. We need to unwind it. It's going to be very complicated to unwind, but the exposure as these professions are now realizing what it truly means to them and why we opposed it at the time is all coming to light. And part of that is because we were only a third of the way through the bill. Just for those at home, I know we're trying to rush through, but when a bill goes through, we go to what's called committee stage, and we can ask questions clause by clause of all the clauses so everyone understands what the government's intent of the bill actually is, or each clause as well. We only got through about 200 of the almost 600. There's a little more than 600. We got through about 200, so about a third of the way through. And then the government brought in what they call closure and closed down debate on the bill and passed it. And so we said, well, wait a second. We come back into the next sitting after the break, and we come back. We say, okay, look, we're not going to try to change the outcome of the vote. We recognize your government. You won the vote. Fine. Can we at least just reopen in committee stage, non-binding committee stage, just so we can ask questions on those remaining two-thirds of the clauses so the public and the professions can clearly understand, especially if there's a court action. Courts use that for guidance as to what the government's intention actually was on legislation. And the government refused to even allow that. So two-thirds of that bill never actually got any level of public scrutiny whatsoever. So it needs to be unwound. It needs to be dealt with. And we need to stop having government trying to control all of these professional bodies with basically the premier's office having their thumb over top of all the health professionals, all the engineers and geoscientists, and now they're trying with Bill 21 with the lawyers as well. That should scare everybody. That it's this mindset of this government that truly is government knows best, and not only do they know best, they are going to control everything as well.
Yeah, they seem very allergic to scrutiny. I mean, we've seen that just last week with Bill 9, where they're trying to make it even harder for the public to see the access freedom of information documents. And I think that's a result of 8 years of stagnant, backwards motion in BC, and now not having knowing what the next step is. They're now trying. They can't blame the guy before because they were the guy before. So it's getting pretty scary here in BC. The next question is from Tammy. Keeping our seniors active in health and mind is critical for aging in place. If we could provide our seniors with affordable physio, chiropractic, and other similar care, we could extend their aging in place in more cases, hence reducing hospital care needs. So, what do you think needs to happen with sort of that more holistic approach in healthcare to
Mhm.
seniors? And certainly, isolationism, especially in remote communities, is a massive problem. How would a Peter Milobar government make sure that those seniors are getting that support to stay healthy and active into their older age?
Yeah, well, again, we not only do we need to figure this out, we need to figure out how to staff it. And so, that goes right back into that K to 12 system that's making sure that we have our post-secondary institutions more targeted on some of the more, I don't want to use the word vocational, but that style of training for making sure that we have capacity in the system, and as they recalibrate what these learning institutions are meant for, and that should be for the broader public good as to filling the gaps of what we need people to be educated in. And and if that, I'm not suggesting that means UBC switches out and everything they're doing is around physiotherapy and everything else, but we have a lot of post-secondary institutions in this province. And there's a lot of pressure on them right now, budgetary wise and programming wise. And I think that, we have to have some hard conversations with some of them. Well, what do we need for workforce training versus what you're wanting to provide,
Mhm.
right? Ultimately, these are yours and mine and everyone watching's institutions. These aren't a president or a senate of that particular institution's
Mhm.
institution. These aren't private universities. These aren't private colleges. These are ours. And we need to actually take a bit more ownership of that, I think, as a collective, and say this is what we need, so we can actually motivate kids to want to see a viable career in these professions and get some decent training, quick training, and get them into the workforce.
Absolutely. Yeah, no, it's absolutely a critical thing. I mean, it kind of goes back to that, how do we keep seniors at home? I mean, it goes right back to the basics, which is if we don't have enough long-term care and we want to try and keep people at home because we know the outcomes are better,
Mhm.
how do we do that? And, it's going to be an all hands on deck drive to make that happen because we're really, really falling behind, and, seniors are getting left in the dust here. We're going to move on to the last question of the evening, and it is from Shelley. What is your thought on the new trend suggesting municipalities get involved in operating family clinics? And that's great because, I understand it in principle, but we're asking so much from our municipalities right now in terms of what they can do with their limited resources. So tell us about it. I mean, your experience as mayor of Kamloops is perfect for this because,
Yeah.
yeah.
Yeah, so for those that don't know, I was a city councilor for 6 years in the city of Kamloops, and then I was the mayor for 9, and I was also a regional district chair and a hospital board chair for two different 5-year stints as well. So a lot of experience in this area, and part of the way I was able to, in conjunction with council and staff, and it was everyone pulling together. We were able to keep property taxes lower. Was we did not jump into areas that property taxes are not designed to support. And I saw Vancouver and other cities jump into the housing file in a big way in terms of operations, even. And we had pressure and we refused. We would work with the province, we would work with BC Housing to find, sites for them to build on. And we got a lot of housing built. But we didn't take on operations and we didn't take on those liabilities for the property taxpayer. I get why even smaller towns do it. I have a very real concern, though, of the slippery slope. But when you see Surrey, of all cities, our second largest city, feeling the need to have to, with the guidance and professional staff they have and the size of operation they have, figuring out a way now to open, I believe it's 10 within their city. I think it's time the province actually admit they have a massive problem. In Kamloops, they opened our urgent and primary care center. It sees very few people in a day. It's very expensive to run, and all of our walk-in clinics closed. And we're seeing that happen. And I've said this for years now.
Same in
We were the
Courtney.
first
Yeah.
one that opened, and I warned everyone. I said, "We're the canary in the coal mine. You're going to celebrate getting an urgent primary care center, and then within a few years, you're going to find all of your walk-in clinics are closed, and you're going to say, what happened? How did this turn into us going to an urgent primary care center run by government, or an emergency room run by government? What happened to my doctor having a walk-in clinic?" And so, again, government knows best, government operates best is the NDP motto. I don't subscribe to that. So, um, I just, I'm not going to, I guess I want to say this. I don't want to speak ill of the municipalities are feeling that pressure to do it, because I fully understand and can appreciate that pressure. And in this day and age, had I still been at the city council table, I might be agreeing to the same thing. And so I think it's just more indicative of a government that is basically almost half hoping that these municipalities take up the slack, and they shouldn't have to be. They should be being funded by the province, and they should be getting run and operated properly.
All right. Well, I think that wraps up the question period. And fantastic, Peter. Thanks for taking the time, and thanks to everybody out there for tuning in. I'll just pass it back to Peter to sort of close with his thoughts on what a Peter Milobar government is going to do uh, for healthcare and seniors in this province. And I'm going to push you for some firm commitments here. I'm not letting you off the hook. So, tell the viewers at home where we're headed.
Yeah, well, thanks for that. And really, again, some quick wins I think for us is to really actually truly aggressively ramp up some of the long-term care spaces that we desperately need. Taking that solid look at the operations of our acute care facilities, and making sure that we actually are truly listening to the frontline staff, getting proper security into hospitals, basic fundamental things like that, so nurses aren't under constant physical threat and harm when they're at workplaces. We need to make healthcare feel like it's a safe space for people, not just patients, but also for workers again. And we've lost that. We need to actually meaningfully get these administrative costs under control, so it frees up more cost for patient care and patient delivery. And so those are the areas that first and foremost I would target in and focus in on, and really start to refocus in on that whole how to bring more capacity in the workplace in terms of various subspecialties and healthcare professionals in. But also, the final piece I'd say is bringing that common sense view to how are we going to actually have, you know, accountability and
Mhm.
transparency and reasonable targets that we're all striving towards, and we can keep recalibrating the targets. Like if we shoot for the moon and we miss a little bit, we're still better off than where we are right now. And there's no shame in saying, okay, we'll take another look at that. Um, Again, I come at this from experience. I come at this of doing things like this when I was the mayor, where we would have our planning department come in and they would put out their whole list of various permits and business licenses and fees and charges and everything else, and they'd say this is what we target for length of time for this type and that type of a permit or a license. We're within range or we're not within range. You could then
Mhm.
ask them in a very public setting, well, why not? And they'd say, well, someone's away on mat leave, or we're backfilling a position. We've had a hard time hiring into a position. So again, it's not about placing blame. It's just knowing where are we in any reference point in time. Is it a realistic goal? Does it need to be changed a bit? You want it to be a reach. You want to actually be striving and not just like the premier is right now, settling for mediocrity because he does that with his budget. He does it with healthcare. He does it with schools. He does it with everything. He's the
Mhm.
premier of mediocrity. We need to actually be doing those reaches, but I think that accountability piece is first and foremost the biggest piece we need within healthcare, just so that everyone truly gets a clear understanding. And the staff, I think, will rally around that because they'll feel respected. They'll feel like they're actually working towards a common goal, that they actually even know what it is, and that they're not always under this constant threat from management of how
Mhm.
dare you point out the obvious that healthcare is failing right now.
Mhm. Fantastic. Well, thank you to the hundreds of people online that have joined us tonight. I know it's been a fantastic turnout, and I know I'm looking forward to doing this again with Peter. Just to remember for everyone at home, we will be voting for the next premier of this province at the end of May, and make sure you stay involved, get engaged. And thank you again to Peter for taking the time.
Yeah.
Thanks, everybody.
And thank you, Brennan. I just want to add one last quick thing. If we haven't cut out yet, or have we cut out? Oh, keep going. Okay. Just want to add, we've done a few of these town halls already. We'll do more, but if you're looking for the previous ones, the easiest way is petermilobar.ca. But I also have a Peter Milobar YouTube page where I have a lot of things on there, including clips from myself in the legislature in question period and other bill debates and things that I've talked about as well. So YouTube's probably the best way to find the whole cache of several years of my work as an MLA as well.
Excellent. Well, thank you so much.
Thank you.